Thank you, Melanie. I'm in Quincy, which is a small community in northeast California. We're actually more Nevada than we are California in culture. We're about an hour due west of Reno. We have a 25-bed critical access hospital. We're in the county seat, a county of 20,000. Our service area is about 8,000 in the community. We're about equal parts Medi-Cal, which is the California version of Medicaid, and then commercial and Medicare, with the inpatient population being more Medicare than the others. We run about a $40 million budget on an annual basis, one of the largest employers in the community. We have three rural health clinics, which are a major driver in the community, about 16 physicians. And we're one of only 2 hospitals in Northern California of our size and critical access that still do OB. And so that's a significant difference for us, do our own ambulance service and those kinds of components. Our mantra here as we went into this was that we wanted a partner to join with us in this program because we see it as a long-term endeavor and activity. And so we wanted to choose well, and I've talked to each vendor very carefully about the issue of partnership. We also have used the concept of form follows function, and we started by wanting to know what the functions were that we wanted to achieve before we just chose a vendor. It's easy for us to get caught up in the sales programs and see it as a total piece and lose sight of what the real criteria are that we're trying to achieve. We started by developing a search group or a selection committee, and normally I try to keep those small at 6 or 7, but because of the scope of this, we ended up with 10, and included someone from the medical staff who was also one of our board members, nursing, clinical areas, rural health clinics, finance was a key piece, and so it was a broad-based group covering all of the different modalities in the hospital so that we were sure to get all the different perspectives as we went forward. The group met on a regular basis, and we started with 5 different vendors that were selected as potential participants in the program for us. Early on, one of them was Cerner, and they dropped out voluntarily because as they looked at our hospital of 25 beds and our size, they just indicated that they really didn't know how to deal with us and we're not the right product, which was good to know from them right up front. So we continued with the other 4. We developed a criteria grid, a decision grid, if you will, if you've done those, in which the group sat down and over a lengthy period of time developed the specific criteria or functions that we wanted to achieve. And some of those were very specific in terms of the hardware and some of the technology that went into it. Some of the others would be how easy it was to install, what the training process would look like. So it was a detailed list of everything that we wanted to achieve and the process we wanted to go through. Once we did that, then we brought in each vendor one by one for in-depth reviews with them on their product, what they could do and how they would do it, and evaluated each one based on what they provided and how against each piece of the criteria that we developed so that we could keep focused on what the product would do and how, and weighted that. Out of that, it came down fairly quickly to 2 vendors. Prognosis and CPSI were the 2 that we happened to choose here. And we then went out and did some site visits and talked to some of their clients to determine how they liked the product, how it was functioning, how the installation went, and those kinds of things. And came back and then evaluated it internally. And normally I don't do a lot of private vote actions, but in this case we had a long, lengthy discussion and then asked each individual in the committee to vote on which product that they would choose. And we were fortunate in this case that when the vote was taken, it became unanimous on one selection, which really made it good going forward. And I say that because having been down 4 different installations on EMRs over my career, none of them are easy. And it was hard to communicate to the folks here who have never done it that it was going to be difficult. It's just the nature of the business. And as we started getting into difficulties and something wasn't the way they wanted it or thought it would be, we were able to point back to the fact that we all collectively made this choice and to remind them that this was what we chose to do. So I think that was a great part of the process. We went into this seeking what I call vanilla, and so part of our criteria as well was the idea that we were going to try and use a product as close to its design model as possible, and we were not going to go into it trying to change the product to meet our existing operations and needs. And for those of you that are in small hospitals like this one, we are set in our ways. The mantra here for when I came in was, well, we've always done it that way. And I found that it was a great tool for us and for me as a new CEO a year ago coming into this facility to be able to bring about change because the system drives it. And so it wasn't because I wanted it or somebody else wanted it. The model is, and we need to understand why we can't do it that way before we change something. So our process really was using a broad-based group, decision criteria grid, evaluating each product against that grid. Where we found variations, we could look at each one and determine how important it was in the organization to us, or was it not important. Came to really, in our case, fortunately, a consensus on the decision, and then we took it to our district board and carried it forward. And I think it's been a good process, especially as there are difficulties. We're all in it together because we all voted on it together and made a common decision. The challenges that I think I faced more than the EMR probably was the culture shift, which probably some of you have. Coming in here, I found that we had not changed policies in some cases for 13 years. And so you can imagine how inbred processes and methods were. And we've always done it that way. It was teach one, they'll teach the next one, and they'll teach the next one. And so the culture was very much inbred. Probably 80% of my employees have never worked anywhere but this hospital. And so as we got into it, we have done a lot of work on communication. We decided that rather than call this an EMR or an EHR or prognosis, we wanted to give it its own identity for us. And so we had a contest for our employees and our medical staff to name it. And out of that, we had many, many names come in, and we chose Eagle Eye with a small I for information, and created a logo that goes with it. And so everything related to our computer installation, our EMR installation, is all called Eagle Eye. And so it gives us a great identifier for ongoing information. We're getting ready to start doing thumb drives so we can give the medical records out to our patients on their thumb drive. And we're going to put the logo and Eagle Eye on that. So I just kind of tied it all together with a local identity. We created an Eagle Eye newsletter. Every Friday morning we send out a newsletter with its own letterhead, what has happened this week, what changes are occurring, that kind of thing. So there's regular information going out. We took the same logo and created a different one with more of a red background to identify it. And if something urgent comes up and it needs an immediate release, or if somebody needs to know about it immediately, we send that out so they know something is happening that they need to identify. I do a bi-monthly town hall, which we require all employees that are working to come to. And again, we do updates on what's going on with the system and what it means to them. We do a weekly morning, Monday morning, with prognosis and the senior team here talking about the implementation and issues that are at hand. Then on Tuesday, we do an executive committee with a smaller group internal to, again, manage the process and implementation. And that information goes out as well. And so we've done a number of things. We try to get out on the street. I get in the hospital at least twice a day, making the rounds, just talking to folks, especially the physicians and others that just are not used to having computers. And so the one-on-one has been absolutely critical and important in the implementation. And for the senior leadership, I think it's been the symbolism. They need to know that the senior leaders are involved, know the issues, are sympathetic to them, and are addressing them. And the culture shift is still taking place. It's still, we've never done it that way before. That's not the way we do it here. But again, I think it's been beneficial to the change in the organization that we're able to use the processes of the new EMR to redesign our workflow, redesign how we do things, redesign our forms, redesign our processes and policies, and it's given us a baseline tool to work with and a reason to do it. And so it's going relatively well. We chose, just one last piece on this, we chose prognosis for a primary reason. It was web-based, and we felt that we could, where we needed, make some changes and shifts in the software that worked for us, as opposed to CPSI or Cerner or someone else. And so we've tried to stay vanilla, but in the culture we have allowed and brought in some changes as needed on an individual basis, and that has been helpful. Folks then feel that they've been heard, and where there was something critical, it was addressed, and prognosis has been good in addressing those for us. So going forward, we're not out of the woods yet. We have one more implementation in August on our clinics, but I'm optimistic that we're moving forward quickly and seeing some significant shift in operations, in processes, and even in the culture view of the world, because they see themselves in a new way because they're using this new model. So I think there's hope. It is a good process. It does take time, it does take patience, and it will change your culture.